Hello, my name is Jordan Canedy. I will be a senior at Buckeye High School this fall. This year as part of the Cleveland Clinic 2011 Science Internship Program at the Glickman Urological and Kidney Institute in the Center for Cardiovascular Diagnosis and Prevention at Lerner Research Institute. My research study is entitled Race-Based Medicine, an Overview of Health Disparities and Innovative Solutions. For certain populations, poor health outcomes due to health disparities are apparent when compared to the population as a whole. These populations include African Americans, Hispanic Americans, Asian Americans, and others. In particular, African Americans have been cited to have higher mortality rates from heart disease, stroke, and other diseases. Compared with their Caucasian counterparts, African Americans are 1.5 times as likely to have high blood pressure, 2.3 times as likely to have infant mortality. Health disparities can be caused by a wide variety of factors. These factors can include socioeconomic factors such as poverty, lack of access to quality health care, environmental conditions, educational inequalities, and the fear of participation in research trials. These factors can also be cultural differences, and they can even include genetic or hereditary factors. What is race-based medicine? Well, race-based medicine is the tailored, personalized delivery of healthcare based on the race of an individual or population being treated. However, it is important to note that race is a loosely defined term, and physicians should be cautious not to stereotype individuals when considering their race. An example of race-based medicine is AHEFT and the use of Bidel. AHEFT, or the African American Heart Failure Trial, is a study in which African American participants were given the medication Bidel. Bidel, in combination with standard therapies, was shown to reduce mortality from heart failure in African American patients by 43%. However, there was no significant reduction in other populations. In African American patients, heart failure has a more aggressive nature. Not only does heart failure occur at an earlier age, it is associated with more advanced left ventricular dysfunction than in Caucasian patients. Instances of myocardial infarction, or MI, are consistently lower in African Americans, and heart failure is more likely to be associated with hypertension. African Americans also have a worse prognosis when it comes to heart failure. They have higher rates of hospitalization and mortality than do Caucasian patients. In this diagram, you can see that heart failure tends to have a different etiology in black patients than in white patients. In black patients, the more common cause of heart failure is hypertension, whereas in white patients, it is coronary artery disease. Prior to Bidel, standard heart failure therapies included beta blockers, angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, and diuretics. However, in AHEFT, a combination of Bidel and standard therapies had an additional 43% reduction in mortality beyond current standard therapies. Bidel has proven effective when combined with standard therapies for heart failure such as the aforementioned ones. Besides the use of medications, there are other ways of addressing health disparities. The Cleveland Clinic has been accomplishing this through the Minority Men's Health Center of the Glickman Urological and Kidney Institute. MMHC uses a multidisciplinary, culturally sensitive approach to addressing healthcare disparities among minorities, particularly African American males. Along with operating a weekly clinic, the Minority Men's Health Center hosts an annual health fair that provides free health screenings for prostate cancer, kidney disease, colon cancer, and many other diseases. Beginning with only 35 participants in 2003, the Minority Men's Health Fair has hosted over 2,500 individuals in 2011. In order to better address health disparities, clinical research is needed. However, there is a lack of minority participation, particularly among African American males, and therefore they are underrepresented in clinical research. The lack of African American participation in clinical research is well documented in the literature. In the article, Why Are African Americans Underrepresented in Medical Research Studies? Impediments to Participation, distrust, poor access to healthcare, and lack of knowledge of clinical trials were all listed as impediments to African American participation. The same opinion was expressed in the article, Attitudes and Belief of African Americans Towards Participation in Medical Research. Mistrust of doctors, scientists, and the government were all listed as barriers to participation. Consequently, MMHC has developed a biobank sample repository in order to engage clinical research participation among minority males. The biobank is a sample repository that collects blood and urine samples from minority and non-minority males. By establishing this biobank, MMHC hopes to examine the relationship between biological causes and actual disease processes on human health in minority patients, to perform genetic research in the pathogenesis of diseases that disproportionately affect African Americans, and to engage minority populations to participate in clinical research trials. Currently, MMHC Biobank has collected a total of 152 patients. The MMHC has proven effective in consenting African American males to participate in the biobank. They have done this through building a trusting relationship with the community, community outreach programs, and by establishing an institution. In the future, biorepositories such as the Men's Minority Health Center Biobank can be used as a basis for studies into the biological causes of health disparities. However, current research has already begun at Cleveland Clinic Learner Research Institute. Along with Dr. Hazen, the Center of Cardiovascular Diagnostics and Prevention has extensively been studying molecular markers for cardiovascular diseases. African Americans carry a disproportionate burden of death from cardiovascular diseases. They are both more likely to be diagnosed with and die from CVD. Along with Dr. Hazen, we have started research that will examine peroxidase 1, or PON1, as a molecular marker for cardiovascular disease in African Americans. PON1 is an enzymatic protein associated with high-density lipoprotein, or HDL. Although originally discovered for its ability to hydrolyze organophosphates, particularly neurotoxins such as pesticides, PON1 has also been shown to metabolize lipid peroxides before accumulation on low-density lipoprotein, or LDL. In doing so, PON1 prevents the oxidation of LDL, which can accrue on the inner walls of the arteries. Studies have shown that both PON1 activity and concentration affect the risk of developing cardiovascular disease. Thus, African Americans may have a lower activity of the PON1 enzyme and subsequently may be less protected from developing cardiovascular disease. In conclusion, it's apparent that for many populations, health disparities are apparent. These disparities have a wide variety of causes and approaches to solving them. The Men's Minority Health Center, through community outreach, has been able to engage a historically apprehensive population. However, more research is still needed into the biological causes of of health disparities among minority populations. These studies will not only be valuable for understanding the biological causes of health disparities, but also to help develop solutions to reduce them. Below is a list of references I have cited throughout the presentation, along with the ones I've consulted throughout my research. Finally, I would like to thank the individuals at the Glickman Urological and Kidney Institute, including my mentor, Dr. Charles Maudlin. I would also like to thank Dr. Stanley Hazen at the Center for Cardiovascular Diagnosis and Prevention at Lerner Research Institute. And finally, I would like to thank the Office of Civic Education Initiatives for their support and assistance throughout the program. Thank you.